Well, hello everybody. Welcome to iCubed. This is our first anniversary episode. Woohoo! Yay! And to help us celebrate this 13th episode, Marc Zosky, the wonderful colleague that started this whole thing with me last year. So welcome back.
Thank you so much. I'm surprised I'm still allowed back on. But
you are
it's an honor.
You are terrific, and I'm so glad we started this whole screencast with you last year. iCubed started out of an idea to really combine visual learning and audio learning, and so the slideshow combining with my discussion with a colleague, I hope brings a different level of learning and retention to all of you listeners and users of this blog. So thank you for listening and being so faithful all these episodes, and we're just going to launch into our very first anniversary episode. Woohoo! Now this patient is actually a very fun case, and it's a 28-year-old female that comes in by ambulance with a seizure. And she told them that she had a panic attack last night. She took 5 of her Xanaxes, and when she woke up this morning, she had another panic attack.
Oh man, I have like bias written all over my face right now. This is a 28-year-old female with anxiety. You're all thinking it. Did she have a pseudo seizure? And is this going to be a really difficult disposition?
Right. I think all of us in practice have already formulated a differential and maybe a bias. Yeah. All right. So the HPI for this patient, she's 28, female. She has a history of anxiety and depression, and apparently a witnessed seizure by EMS. The call was initially made by the brother because of the patient's complaint of dizziness and the inability to walk. EMS is called. They arrive and they walk her over to the gurney, and they saw her have a seizure, an actual a clonic-tonic seizure with a post-ictal confusional state. Mm-hmm. What do you think now?
I'm thinking it's probably a real seizure, especially since it's on the iCubed illustrious podcast, screencast, I should say.
All right, so yeah, the more you hear about it, the more it seems legit. So you walk in the room, you see her, she's sitting there. She's morbidly obese, a little bit pale, young lady, and she's alert, she's visibly anxious. She is diaphoretic.
Yeah, I think that's what popped out about me the most, is patients that are diaphoretic usually have some underlying pathology.
Right. That's right.
If your patient sweats, it ought to make you sweat.
She's conversing with you, a little slow to answer, but she's definitely able to answer your questions pretty appropriately with clear speech. She's a little shaky and tremulous too. You notice that just walking in. You really pick up a lot just simply looking at a patient's general exam. So we get some vital signs. Blood pressure's 119 over 57. Her heart rate's 152.
She's pretty tachycardic.
Yep. Respirators are 24, and I think those are legit.
Did we get a blood glucose, Dr. Lee?
Good question.
Ooh.
Oh.
I just took my oral boards.
You did.
And that is step 1, 2 large bore IVs, O2 monitor, full set of vitals, and the AccuCheck.
Should I ask you if you passed your boards?
I did pass my boards.
Okay, excellent. You're going to stay with our group then?
Yeah, I don't think I'd be allowed on the podcast if I failed my boards.
That's right.
It's one of the things we feel so foolish, like 2 hours later when the chemistry comes back, you're like, oh, their sugar's 30. That's not good.
So she's got a SAT of 98% in Roumare. Her temp is 37.6, just a little bit high. Proceeding with her exam. We talked about this a little bit earlier. She's a little diaphoretic. She's pale. Of significance, there is no nystagmus, so that's a pertinent negative. She's tachycardic. We knew that from the vitals. And she has unlabored respirations. The rest of the exam, what really stood out was that she had 3+ patella.
Deep tendon reflexes?
Yeah.
I don't know if I own a hammer.
I used the back of my scissor, my trauma scissors.
Wow.
Yeah. So she definitely had a hyperreflexia in her patella tendons. She, like I said, was alert and able to answer my questions, although she was speaking slower and answering slower, but she had a clear speech and no slurring whatsoever. She said that she's been having a panic attack for about 4 hours, right? She couldn't sleep last night, and at first she said, I took 2 Xanax, and then I took 5 pills of my Anti-Depressant, but I can't pronounce it. I don't know what it's called. It has an X in it, though.
It's when they usually say, I think it's a blue pill, or it's white.
Right.
You know what it is, Doc.
You know what it is. Yeah,
I don't.
What now, Dr. Zosky?
Oh, man. now when I see that she's got anxiety, depression, she took a whole bunch of pills and she's got hyperreflexia and tachycardia and a seizure, I think, what's the worst thing this could be? And right off the bat, the worst thing I think this could be is serotonin syndrome or I can't even pronounce it. Neuroleptic malignant syndrome or NMS.
Yes. Right.
But I mean, also a lot of things, maybe she didn't take her benzos. Maybe she's been taking chronic benzos and abruptly stopped them. She's been taking other pills. So maybe it's a benzodiazepine withdrawal seizure.
Right.
Maybe it's an alcohol withdrawal seizure. Maybe she has epilepsy. But the scariest thing that I'm thinking right now is serotonin syndrome with the hyperreflexia, because I don't know a lot of things that cause that.
Right. That's right.
Ooh, I've got a good one. Tca Overdose.
Ah, excellent.
Yeah, because they get real, I don't know if they get to 150s, but they get really tachycardic, and then like an EKG can help you make that diagnosis. So I'm going to add Tca Overdose on there too.
So and then another very simple differential is just some pathomimetic toxicity of some sort, right?
Absolutely.
She maybe took, not really being complete honest, maybe she took, Adderall or something, a whole bunch of Adderall. And then withdrawal is always in a differential, in any kind of if you're thinking of tox differentials, any withdrawal. So there's a few very important differentials to think about.
Think of something funky like thyroid storm.
Yeah.
But I think they get real hypertensive, but they get really tachycardic and altered like that. But she seemed to have been coming too, so probably not. I feel like
that's a great one.
I feel like that case they'd be getting much worse.
Yeah, but that's a great differential I wasn't thinking about. But all right, I think that part of the history was important, whether this was intentional or accidental.
Absolutely.
Just in terms of just the degree of toxicity that the patient may experience. So I happen to love toxicology, and I sensed the toxicology case right away when I looked at her.
I feel like we all get that sense too with like young people that are sick, that don't have a lot of medical history. It's, it leads us down that path. There's something tox going on. So past medical history, let's see. So I don't see seizure disorder there. I don't see any multiple sclerosis or brain tumors or anything like that. Pretty benign surgical histories, only on Motrin, no drugs.
Yeah, it's pretty straightforward, a simple history on this young woman. A very important part of her history was, or the HPI was that she at least said to me she had taken an antidepressant and she's on one. What would you do at this point? How would you pursue the diagnosis on her?
Well, real quick, any tachycardic or actually any young person, especially with seizure, I was getting EKG because you can look for Tca Overdose. And sometimes, this one's pretty reliable because the EMS saw it, and EMS is really good at describing seizures. But if they weren't there, I didn't see most of it. Sometimes syncope will have a brief episode of shaking. So I'd get an EKG too. Is there anything like Brugada or WPW, or is there an obvious dysrhythmia on the EKG?
I kind of pretty much did the whole tox workup because I really sensed this was a tox case. Very routine workup.
And everything looks pretty good.
Yeah, it does. The UDS was only positive benzos, like she said, Xanax, The CBC is unremarkable, CMP pretty normal on her. Potassium says a little bit low. And then the alcohol, salicylate, and acetaminophen, all that was negative. EKG, very key in any kind of workup for toxicology. What do you think?
Just looks fast is all. I mean, and then you just like the non-specific ST kind of scooping ST depressions and probably just rate dependent.
Correct.
But otherwise, I think it's just fast.
Right, and so you cannot exactly rule out a Tca overdose because the most common EKG finding really is sinus tach. It doesn't entirely rule out TCA, but at least I don't think this is severe Tca overdose. That's going to rest on you.
Yeah, the buzz findings aren't there besides just sinus tachycardia.
Right. And then in terms of possible syncope, I don't know. This is just a sinus tach, and it's not. At least it's not SVT, and it's not atrial fib, and it's not V-tach, right?
Exactly.
I did a chest film. The chest film was really unremarkable, very normal looking. The CT brain came back, and that was also very normal. And then so the family shows up. There's a twin sister, an older sister, and a father. And then, as is often the case, the rest of the story.
There's more.
So now that the family is here, the patient remembers that she took 2 tablets of Effexor every single time she woke up throughout the night.
You know, I'm no pharmacist, but that seems like a lot of Effexor.
Yes. So I'm guessing over a period of 8 hours, she took 10 Effexors, and she had been on it for a few months for depression. What do you think now?
Oh man, I'm thinking serotonin syndrome. Yeah. Totally.
So I called our Banner Outreach folks to talk to toxicology to transfer over to
What did they tell you too? Because I don't even know the answer to this. Did they say just benzo titrate to improve hemodynamics, or?
No, I don't remember specifics
They say you'll need a small amount of benzos. I don't know if I know the answer because I've only seen one of these.
Yeah, right. So that's what we'll talk about in the rest of the podcast.
You can learn me something. But I will say this is actually a really kudos in terms of, I think you and I on Shift talk a lot about just our own personal biases and anchoring bias. You see enough anxious 20-something-year-old females and you just poo-poo their complaints. They seize, but now they're alert and they're oriented. They're tachycardic because they're anxious.
Right.
Oh, the workup's normal. You probably had a panic attack and go home. If you don't take this patient serious, I'm serious. Like, if you don't take this patient seriously, they go home and die. Like, if you just on a busy shift and just miss their complaint. So, good job on the physical exam. She's diaphoretic and super tachycardic, and the reflexes. Yeah, you can't fake hyperreflexia.
That's really true. That's really true. So, Mark, you said that you've seen one.
I've only seen one.
Want to tell me about that?
The one I saw, I almost called the patient a liar, but he was too altered to know that I was sitting there judging him at the bedside because I saw him a week earlier for chronic pain, and he arrived tachycardic, diaphoretic, hypertensive, and so altered he couldn't answer questions, and I was screaming at him and demanding he open his eyes and talk to me and stop being foolish. But then, I don't think I did reflexes right away, but I pushed on his feet. Yeah. And he had the most rapid clonus I've ever felt in my life. Just bum, 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 bum. And then I checked a reflex too, and he was really hyperreflexive. So
now you felt foolish.
And then I felt foolish and said, "Sir, I apologize. We're gonna treat you right here.
We're gonna take you seriously now."
And we gave him an our situation. He was already so altered. I called toxicologist, said, "I've never seen serotonin syndrome before. What do I do?" And they said, "We'll give him benzos." And I said, well, if I give him any more benzos, you know, he's going to be obtunded and not protect his airway.
He was already sleepy?
He was always really somnolent and drowsy.
I see.
So we intubated him and just gave him high-dose benzos and got extubated the next day and did very well.
Do you know what he took that brought on the serotonin syndrome?
He was taking a whole combination of benzodiazepines, narcotics, antidepressants, and antipsychotics.
Oh, jeez.
So, yeah. So I don't exactly know which medication, quote, broke the, straw that broke the camel's back.
Yeah. I followed this patient's case over at the university, and they implemented the treatment for sort of moderately severe serotonin syndrome, which is just withhold the agent, the serotonergic agent, and then they gave her benzos, and then she really cleared up. So she did well, yeah.
I feel like you get more fun cases than me, honestly, or maybe you just...
I'm picking charts, obviously. All right. So in all of my episodes, I try to focus our learning to 2 points, just so that we're not drowning in information, because there's just so much information overload. So the first learning focus, obviously, is a serotonin syndrome. Now, did you know that the diagnosis of serotonin syndrome is really a clinical diagnosis?
I did, because I had to look it up when I had mine.
The couple of references I looked at, one of them said that the gold standard for diagnosing serotonin syndrome is actually diagnosis made by a toxicologist. Okay, and then in Up to Date, I looked at, that's the most recent reference, and in there they talk about a diagnostic criteria called Hunter criteria for serotonin syndrome, and this really makes it simple for us. You just have to be taking a serotonergic agent plus one of these the following criteria. So on this list here, number 1, spontaneous clonus. Number 2 is inducible clonus plus agitation or diaphoresis. Now my lady had hyperreflexia, not clonus per se, but she was definitely diaphoretic. I didn't specifically check for ocular clonus, but that's interesting. I'll try to remember to do that. So number 3 criteria is ocular clonus plus agitation or diaphoresis. Number 4 is where my gal falls in. She had tremors and she was hyperreflexic with the 3+ DTRs. Plus she's on the Effexor. And then criteria number 5 was just hypertonia plus temperature above 38 plus ocular clonus or inducible clonus. So your guy had inducible clonus, it sounds like to me. And so this really breaks it down. It makes it easy for us to make a diagnosis of serotonin syndrome. Serotonin syndrome has a spectrum. It goes from very mild to really critical, where they have to be intubated and put in the ICU. There's really a lot of resources out there, and I'm trying to kind of drill it down to just a few interesting, pertinent points. Basically, the mechanism of serotonin syndrome increases serotonin in your brain, essentially. There's 6 basic mechanisms. The first one would be just an inhibition of serotonin uptake. Okay, that makes sense. And one of the examples of that is taking tramadol. Did you know that? Tramadol?
I had no idea.
Yeah. I used to prescribe tramadol much more freely, but combining tramadol with, let's see, hydrocodone or Effexor or Zoloft, that can give you serotonin syndrome. Another mechanism of serotonin syndrome is decreasing the serotonin metabolism. Some drugs out there do that. Number 3 mechanism is increasing the synthesis of serotonin. Number 4 mechanism is by increasing serotonin release from the synapses. And then number 5 mechanism is some drugs activate the serotoninergic receptors, actually. And then the last mechanism, SSRIs will inhibit some cytochrome P450 enzymes, and those enzymes that break down certain serotonergic drugs can result in increasing serotonin levels. So essentially, the mechanism for serotonin syndrome is that whatever drug interaction you're having in the body increases the level of serotonin in your brain. So earlier we did talk about differentials of just this patient presenting in this clinical way, but in terms of serotonin syndrome, other diagnoses that mimic that would be we talked about number 1, neuroleptic malignant syndrome is one of them. Anticholinergic toxicity is another. Malignant hyperthermia, I've never seen that, although it's very similar to NMS. It could be a sympathomimetic toxic withdrawal. We talked about that if you were on, let's say, Valium or Xanax and you're withdrawing. Meningitis and encephalitis can definitely mimic something like this. Something I didn't know until I looked it up, there's actually a specific antidote to serotonin syndrome, which is cyproheptadine. Did you know that?
So I knew that as a buzzword for boards, but in my case, when I called tox, which is one of the only times I ever called toxicology, I'm not calling for medical legal, I'm not calling this, I need to talk to your toxicologist now, because my patient is sick. Right. And I said, do I need to give this guy cyproheptadine? I've never given it, I'm excited. And they went, no, just give him benzodiazepines. And I said, very good. Okay. And I never asked why I didn't have to give the cyproheptadine. I just said, sure, I'll dose him up with benzos. But the reference, I don't know whether this would be it would stand in court or not. But anyway, the reference I had read said that the cyproheptadine was used only if you failed to control the vital signs. Yeah, and the patient was failing to be calmed by the benzodiazepines. That makes sense. She's still altered, tachycardic. Then I guess give it, but I feel like benzos are the cure-all for all tox cases. Yeah, that's probably not too far from the truth. So then, overall, just in summary, the management of serotonin syndrome, depending on obviously the severity of the patient, but management would be, number 1, obviously take them off the drug that's causing it. Give them supportive care, and that's the treatment for most tox cases. And then cyproheptadine, like we talked about, if they aren't responding to the benzos. Now, we should try to avoid Haldol or droperidol, apparently, because they have anticholinergic properties that would add to the syndrome, manifestations of the syndrome.
And then usually they say the symptoms will resolve within about 24 hours, and even less than that in the mild cases, maybe even about 6 hours. So I would say that if you have a very mild case, if you watch them in the ER, like for 6 hours, you can probably just send them out if they calm down. Yeah, I think that's reasonable, because a lot of tox cases, you can just observe them in the ER for 6 hours and they're fine.
I feel like that's the golden window too, 4 to 6 hours.
Yeah,
I always say 6 hours.
Right. I've done that all through my career. And then in terms of moderate cases, those should be admitted. Like my lady, I admitted her, obviously. She was a little bit higher, moderately severe. Those who are really sick, it sounds like your guy was really sick. Those really sick patients need to be intubated, sedated, lots of benzos, admitted to the ICU. And then if you have to paralyze them, they recommend that we avoid succinylcholine, just because if the patient for some reason has renal failure from those toxicity or rhabdomyolysis, then you would take a chance of having a hyperkalemia in those patients. So they recommend vecuronium for intubation. And then the esmolol is the beta blocker of choice for the severe hypertensive ones, or you can use niprite. So very good.
Learning focus number 2.
Yeah. What do you think?
Oh man, I'm stumped.
So I had a patient come in one day and said, I just feel really weird. I just came off of my Zoloft and I just feel really strange. I've been weaning off of it for like the past 2 weeks, and I just suddenly broke out in tears and crying, and I feel shaky, and I just feel really strange. But my doctor said I can wean off over 2 weeks. What do you think?
I don't know. I feel like the patient did everything she was supposed to do, and that's what I tell people. So,
well, there is a distinct syndrome called...
I had no idea that existed.
Yeah. I did not either until I had 2 patients this year, just within this past calendar year.
And now you can say, ma'am, you have, let me read it, Anti-Depressant Discontinuation Syndrome, or ADS.
That's right. It's actually ADDS.
Oh, there it is. ADD.
So I did not know this syndrome actually existed. This syndrome, ADDS, Anti-Depressant Discontinuation Syndrome, mostly applies to SSRIs, but there is this syndrome as well for MAO inhibitors as well as TCAs. But mostly it really applies to SSRIs because that's the most commonly prescribed antidepressant nowadays, right? Their symptoms begin approximately 2 to 4 days after the abrupt cessation of the antidepressant. And you must have been on it for about a month or 6 weeks. It is often seen during tapering, or even if you miss doses on these short-acting ones such as Paxil and Effexor. To prevent the ADDS, you should gradually discontinue your SSRI over 4 weeks with a very slow taper towards the end. There's a mnemonic. I don't know what you feel about mnemonics, but I kind of stopped learning mnemonics after I got out of residency. But there's a mnemonic FINISH, FINISH, which stands for flu-like syndrome, insomnia, nausea, imbalance, sensory disturbance, and hyperarousal. And apparently, in this one reference I looked at up to date, it says it's seen in up to 40% of patients upon abrupt antidepressant discontinuation. There's another reference I looked at, a pharmacology reference, talking about 20% of patients.
That's a lot.
That's a lot,
yeah.
And I think that we've probably seen this more than and not recognized it.
Probably.
All these many years. But lastly, the ADDS is seen in MAO inhibitors as well as TCAs.
Or we said something like, your labs look fine, your vitals are great.
You're just anxious.
Go see your doctor. You look good.
Right. So then I did find a really terrific article in a pharmacology journal, actually, and it talks about the ADDS. And the FINISH mnemonic is very helpful. They have sensory symptoms, which are like very strange paresthesias. Like they have this equilibrium. They kind of feel lightheaded. They're sort of all balanced feeling. There's some general somatic symptoms. There's affective symptoms.
These are all like those vague complaints we hate picking up. Like 35-year-old who just doesn't feel well. Well, why don't you feel well? Well, I'm dizzy and maybe my leg tingles and I'm you know, I don't feel
I feel
well.
nauseous.
I feel nauseous.
Yep, and I can't
I'm weak,
sleep. Yep,
and I go, oh no.
Well, the key to the diagnosis, obviously, I think, is the fact that they were just on a SSRI.
Well, that involves taking a history, Dr.
Yeah, you mean actually talking to the patient? So what the patient I had last week had all these symptoms, and it was very clear just from history. And I did rule out other things just to be more thorough, but it was very obvious that she had just come off the last dose of her Zoloft, and then 2 days later she had every one of these 6 symptoms.
She's 6 for 6.
Yeah.
So what do they tell you to do? Do they want you to restart at a tiny, tiny dose and taper off from there, or? So
the recommendation is just start them back on the reference I looked at didn't talk about specifics or how much, but yes, just restarting them back on what they were on before is recommended. Yeah, and cool. You know, just common sense wise, I tell them, well, let's just get you back on what last dose you were on, and then we'll just re-taper you, but in an even slower. The other day, my young lady who came in with that, she said, could I just stay off of it? How long will it take for me to just get over these symptoms? Because she really wanted to be off. And I said, roughly, another week or so probably. And that's what these references say, probably another week. You'll get over, depending on which SSRI you're on. So.
Cool.
Yeah. So that's it.
Great cases, Alice Lee.
Thank you. Thank you again for coming back to celebrate our first-year anniversary.
That's right. It's a big deal.
Yay! 13 episodes. I'm so excited. I hope everybody enjoyed this case. I thought this was a fun case and relatively easy to diagnose, and it was good that she did very well when after we transferred her. So once again, thank you for listening and watching, and I hope that you learned something from our discussion here. We'll see you and talk to you next time. Bye.
Bye.